Aisha. I will introduce Professor Florencia Torche, who is Professor of Sociology at the Stanford School of Humanities and Sciences. Professor Torche holds a BA from the Catholic University of Chile and an MA and a PhD in Sociology from Columbia University. She is also a scientist with expertise in social demography and social stratification, and her research examines inequality dynamics, including intergenerational mobility, disparities in educational attainment, family dynamics, and assortative mating. She also investigates the influence of early exposure on individual well-being and inequality. So welcome to the Berkeley Demography Brown Bag, Professor Torche.
Thank you so much, Felipe. Thanks everyone for being here or there, I should say. Can you hear me okay today?
That sounds great.
Okay?
Yes. Yeah.
Okay, thank you so much. It's hard to tell these days. So what I wanted to share with you today is collaborative work with Jenna Nobles. Actually, we were just talking about another of her projects. And this work is on the impact of the pandemic on infant health, and specifically my angle as a scholar of stratification is going to be on inequalities in infant health, right? Early life health. We receive funding from the NIH, the NSF, for which I'm very grateful. I'm having trouble with my mouse. Oh. Perfect. All right, so as you all know, the COVID pandemic has had an unprecedented impact on population health and well-being. And this impact, we already know, has been stratified by socioeconomic advantage, race, ethnicity, and other dimensions of population vulnerability. We want to focus on possibly less visible consequence of the pandemic, which is its impact on infant health. And we care about this for many reasons, but again, from the perspective of stratification scholarship, one reason is that if the impact is unequal, it may contribute to health and well-being of the next generation and to the intergenerational persistence of inequality and disparities. So today, I'm going to focus on one particular indicator of infant health, namely preterm birth. Why preterm birth among the many indicators we could consider? And because it's a leading cause of infant mortality and morbidity, and it is a determinant of individual development and well-being throughout the entire life course, right? So it has long-term consequences. Early in the pandemic, I would say a commonsensical expectation was that the pandemic was going to have a detrimental effect on preterm birth. That is, it was going to increase the preterm birth rate, observed preterm birth rates. However, many studies in wealthy countries, in advanced industrial countries, whatever that means, have found the opposite, found a decline in preterm birth during the pandemic. That's already a very well documented finding, at least for the early period of the pandemic. And here you have two reports of this finding, right? On your left, you have a New York Times article that asked during the COVID lockdowns, some doctors wondered, where are the preemies? And to your right, you have an early published research article reporting an unprecedented reduction in births of very low birth weight and extremely low birth weight infants during the COVID lockdown in Ireland, claiming to exploit a natural experiment to assess that effect. Note, by the way, that both reports very explicitly attribute any reported findings to the lockdowns. Now we know that we cannot do, but that's the way in which this was framed earlier on in the pandemic, at least, and continues to be framed for that matter. That's that presents a puzzle that's interesting for researchers, right? There's good reason to think that the pandemic may have induced an increase in preterm birth. We were finding a decline. And this decline was attributed to several factors, right? People mentioned the reduction in work-related and commute-related strain and stress among pregnant persons. Perhaps the pandemic increased the opportunities to exercise, to rest, to sleep, right, among pregnant people, reduce exposure to other infections, particularly influenza. Maybe it resulted in a decline in air pollution and so on. This makes sense, but it was, and mostly still is, speculative. On the other hand, there are several factors that triggered by the pandemic that it's plausibly, it's reasonable to expect that they may have increased preterm birth. For instance, the economic disruption at the beginning of the pandemic, the increased stress and anxiety, those factors could have resulted in an increase in preterm birth. This was very puzzling to us. And of course, you know, this puzzle may be easily explained if someone digs a little deeper and considers both heterogeneity in the effects of the pandemic across the population and the potential existence of multiple pathways of influence, right? Which is what I would like to focus on to try and shed light on this puzzle. So in terms of heterogeneity, the effect of the COVID shock could be negative for some populations defined by many factors. I'm going to focus on socioeconomic resources, but those effects could be neutral or even positive for other populations, right? And this heterogeneity might be driven by differential availability of resources, right, to respond and to shield yourself from the pandemic, the differential likelihood of experiencing adversity, right? Prior experiences of adversity may foster resilience, that's one possibility, or in contrast, may make individuals more sensitive to a novel shock. And of course, heterogeneity may also be shaped by the different policy responses, protecting different groups, right? In terms of different pathways of influence, we are going to consider at least a distinction between a direct pathway, that is any effect that COVID infection, direct effect, or that COVID infection during pregnancy may have on preterm birth, right? So that would be a direct pathway. And then indirect, a myriad of indirect pathways that may comprise any effects of the pandemic on stress and anxiety, access to healthcare, economic vulnerability, among many others. So I think it's very recent, and I think we're not the first ones to consider heterogeneity, diverse pathways of influence, right? But data constraints have, to a large extent, prevented the examination of these two dimensions. Ideally, researchers would rely on a population level data with no selectivity and timely release, right? To examine how, you know, changes in infection levels and responses to the pandemic correlate with changes in outcomes. Vital statistics, as you may know, however, are released annually with substantial lag, right? So we need to wait for a long time in order to examine what happens, what has happened during the pandemic. And also those data are released with the coarsening of key measures, like, for instance, location, right, to capture a location of exposure, and birth timing, right, detailed birth timing. So in order to circumvent these limitations, what we did was to go directly to the state by state, to request restricted access, continuous release, vital statistics. These basically we're going to work with birth records, right? And to date, we have data or are in the process of getting data from California, Florida, Jersey, Alabama, and Wisconsin. This is growing to establish agreements with. Link these birth records with a measure at the county zip.
Is that true of other people or just of me?
Could you
I don't know how to fix it.
Yeah, sound is breaking up.
I don't know how to fix that, but
go on?
One thing might be if folks other than Florencia could turn off their video. Sometimes it's a bandwidth issue. That might help with the sound issue.
Or messages that I'm how any better people. Can you hear
It's still breaking up. It's still breaking up, at least for me.
A video, is that a little better now? My video off?
It's a little bit better, Florencia. It's still a little choppy.
Little chop. I don't know what else to do. For me to log off and join again.
Yeah, that might, maybe that will help.
Okay. So let me leave and come back right away.
Sounds good. Thank you. Thanks for everyone's patience as we figure this out.
All right. I'm back. Is this? Can you hear me a little bit more clearly now?
Yeah, that's much better.
That's much better. So I'm gonna just keep my video off, and if you could make me a co-host again, so that I can share my presentation.
Sure.
Thanks again for all this, logistics. Okay, here we go. So, all right. So you can see, I don't know, I think there was a question. So the sound is working well now. Thank you so much.
It's all working great. Thank you.
Thanks everyone, whatever it was. Let me pause and say, maybe you didn't even hear what I said, but if there is any questions, need for clarification, this is a great time to pause, and any questions you may have, or the request to repeat something that wasn't clear before because of the sound, please let me know before I keep going.
I think we're good.
Okay, perfect. So let's continue. So so with that, let me tell you then what I will do today. We are going to examine the consequences of the COVID pandemic on infant health. I'm going to focus on California today, not only because we're all here, but also because it's a very large and diverse state. I'm going to use this as kind of a proof of concept for the broader project. And as I mentioned before, I'm going to really pay attention to socioeconomic heterogeneity in the effects and diverse pathways of influence. And we're going to jointly evaluate 3 questions. First, so 1A is the question is what are individual level predictors of mother's COVID infection during pregnancy? Let me pause here and say I'm going to talk about mothers as a shorthand, but what we should think of is birthing persons, right? Who could or could not be mothers. It's just following on, the convention and the literature. I'm going to say mother. Then 1B is, again, we're going to stay at the individual level, and I'm going to examine individual level consequences of mother's COVID infection on preterm birth. As you see, of course, these 2 questions are questions that are addressed at the individual level, linking, right? Who gets COVID during pregnancy and what are the consequences of that? And then I'm going to move to the aggregate level. I'm going to move to the population level. I'm going to examine trends in preterm birth during the pandemic with a focus on socioeconomic heterogeneity. And of course, question number 2 will address multiple pathways, right? Not only any effect of individual level infection during pregnancy, but everything else that changed in the world in order to assess the overall aggregate changes in preterm birth during the pandemic. So that's the roadmap. Why California? I mentioned it's a very large and diverse state. 1 out of 8 births in the US happen in California. And it was one of the first states in the US to respond to the pandemic. A shelter in place order was issued on March 19 of 2020. It feels like ages ago. With the caveat I mentioned, I'm not going to even try to treat the shelter in place as a treatment that whose effect can be estimated, right? Critically, for our research purposes, California birth records began including information on the COVID infection status of all persons giving birth on June 2020. This is incredible to understand the effects of infection on birth outcomes. To the best of my knowledge, California is the only state that does that still today, in spite of my best efforts to promote the idea among other states. And this is what we're going to rely on. I should be very clear. This is COVID infection measured at the time of labor and delivery for the most part. In virtually all cases, that's what we are measuring, right? And there's no information about the severity of infection, which would be great to have, but we don't have this. Regardless, this is a very important information. All right, so some descriptives. These are just a graph showing the trends in infections. This is for the overall population in California. We start the vertical line is the week where the shelter in place order was issued, right? And this is new weekly cases. And you see a gradual increase, a small increase during the summer of 2020, then a major winter peak. This is the winter of 2020 to 2021, very sharp decline. And then the data I'm going to use today goes through September of 2021. So we see the beginning of the Omicron surge, but we are not measuring that yet. We're including now, actually, because we have the data already. So we end in September of 2021 for now. This is the entire population. This is among pregnant persons, right? Based on the birth certificate data, the proportion of persons giving birth with a positive COVID test at the time of labor and delivery. And you see a trend that closely patterns the population level trend as it should, right? This is the summer of 2020. Then the substantial winter surge in infections, in which about 7%, a little bit more than 7% of pregnant persons tested positive for COVID, then a sharp decline, and then an incipient increase due to the Omicron variant. All right, So let's start with the questions, right? First, let's talk about the individual 1A, individual level predictors of COVID infection during pregnancy. Overall, 2.7% of persons giving birth tested positive for COVID during the period of observation, but the risk of infection is not homogeneous, as you know, no one would expect that. And this is the result of a model predicting the probability of infection. This is a two-way fixed effects model, right? So I'm adding a fixed effects for a hospital or birthing place and for week of birth. And I'm plotting here the association between markers of socioeconomic advantage and the probability of infection, where the red vertical line shows you the mean, the aggregate infection rate of 2.7, right? Much variation across that aggregate. Based on educational attainment, we see a monotonic increase in the risk of infection as education of the mother's education declines, right? So those with a graduate degree, the probability of infection is less than 2%, but those mothers with less than a high school diploma, the probability of infection is almost 4%. Then if we measure disadvantage at the zip code level, so this aggregate measure, right, I divided zip code level socioeconomic advantage. I created an index based on poverty, education, a proportion of minority population, and so on at the zip code level. And then I divide this in quartiles, and we see the same monotonic increase as disadvantage increases. Finally, by race ethnicity, we also see substantial variation. To our surprise, the most salient source of heterogeneity here is a much higher risk of infection among the Hispanic population giving birth. 3.5% of Hispanic mothers tested positive, and much less variation among other racial ethnic groups, including non-Hispanic whites, blacks, and Asians, right? So, and remember, this comes from the same model, right? So these effects are net of each other, right? It's suggesting, of course, the compounding of disadvantage. So there's a question here, would like to see by education. Within the race ethnicity groups, Ron, you got it, because that's the next slide, which is, of course, the prior model assumes that we live in a world in which there is no interaction, right, across dimensions of disadvantage, which is most likely unrealistic. So we relax this assumption and we allow for these intersectional inequalities, if you will, in a very crude way. Of course, we're just adding interaction terms. But here we see education. The question by Ron exactly preamble the main finding when we relax the assumption that effects are not interactive, or I should say associations. And here is the educational gradient for each racial ethnic groups. And what we see is that the educational gradient, so we have our 5 educational levels, right? Mothers with less than a high school diploma, all the way to those with a graduate degree. And then for each racial ethnic group, the lines identify different groups. And what we see is that there's a gradient for all groups, but the gradients really pale when we compare with Hispanics. So the stratification is much more pronounced among Hispanic persons giving birth, and quite pronounced, right? We should notice at the same time that the risk of infection among persons giving birth is highest for Hispanics at every educational level, but the gradient is more pronounced. And based on this quite stylized analysis, we immediately identify a group that is at highest risk, right? Which is disadvantaged in terms of education, right? Educationally disadvantaged Hispanic persons giving birth. We can go a lot more granular than this. incorporating information about location of residence and so on. But this is already, just to give you a sense of the relevant substantive findings on the one hand and the kind of findings that might be relevant. All right, so let's just summarize, take a stock of this very first question about the individual level predictors of COVID infection during pregnancy. The risk of infection is strongly stratified by SES and is similar across racial ethnic groups. To our surprise, coming into this, we thought that African American populations were gonna be exposed to much higher risks, except for Hispanics, right? The single most vulnerable group, based on our analysis, is Hispanic mothers with low educational attainment. This matters because to the extent that COVID infection during pregnancy increases the risk of preterm birth, the stratification of infection risk will contribute to the intergenerational persistence of inequality, right? So let's move to that second question, right? The association between infection during pregnancy and birth outcomes, specifically preterm birth. So let me move to that question 1B. We're still, we remain at the individual level, right? But now move from infection to outcomes, birth outcomes. This is what I'm going to show you is parameter estimates from, again, a model, a fixed effects model predicting the probability of preterm birth, right? And first, I'm going to show you just the raw gaps in preterm birth between mothers that tested positive for COVID. That's this parameter estimate and confidence interval on top, and mothers who did not test positive for COVID. No covariates, nothing, just a difference in means. And what you see here is a massive gap, right? The preterm birth rate for non-infected mothers is 7.4%. For preterm mothers is more than 10%. So a huge, if you read this causally, a huge impact of infection. When we account for socioeconomic and demographic covariates, right? Mother's age, birth parity, education, race, ethnicity, foreign-born status, and community that is zip code level of socioeconomic disadvantage, we see that the gap persists almost unchanged. So the vertical gap in the probability of preterm birth between mothers infected with COVID and those who are not infected with COVID, it suggests a very large impact of COVID infection during pregnancy on preterm birth, right? A negative impact. Let me pause. Is there heterogeneity across mother's age in this effect? That is, can different distributions in mother's age across race, ethnicity, or education explain some of the disparities? Well, we control for age as a confounder, right? But if we expand the question to differential effects across age, we didn't find substantial differences, substantive or statistically different, significant differences by age. I think I'm happy to show you, additional models later, but overall we didn't find much in terms of age.
Florencia, you're welcome to ignore the chat for now, and I'll monitor it for you.
You can moderate for me.
Yes,
Thank you so much.
Yes,
yeah.
Yes, feel free.
Oh, awesome. Okay. So that's the overall main effect. So let me return to my analysis about inequality, stratification in this effect. Is the effect similar across groups defined by socio-demographic factors? And we did it for all factors, and I'm going to show you the ones that I've showed already, right? Because I'm mostly focusing on socioeconomic disadvantage now, but this what I'm going to tell you extends to other factors. So I'm repeating the exercise here again. The vertical distance between the circles and the triangles is the negative effect of COVID infection on preterm birth, right? The extent to which COVID infection during pregnancy increases preterm birth. But I'm going to do that for all racial ethnic groups. And again, to our surprise, a little bit unexpectedly, we find that the negative effect of COVID infection on preterm birth, the extent to which there's an increase in preterm birth, showed here by the dotted line, right, associated with COVID infection, is rather similar across racial ethnic groups. So the lines, the two lines, are kind of close to parallel, right? Suggesting that the negative effect is homogeneous across groups. The same or is the case when we stratify by socioeconomic disadvantage. There's a educational attainment of the mother. There's a negative effect of COVID infection during pregnancy for all groups, but this effect is relatively similar, right? This based on the hypothesis that disadvantaged groups may have differential access or treatment by the healthcare system, right? Or that they may have differential access to health enhancing innovations, we thought that these gaps we expected these gaps to vary and be wider for disadvantaged groups, but we don't find that. That, I suppose, is good news, right, in terms of stratification, although the overwhelming finding here is that COVID infection during pregnancy strongly predicts an increase in preterm birth, right? So let me take a stock of this second question, 1B, COVID infection during pregnancy has a large adverse impact on preterm birth, increasing the probability by 2.5 percentage points from 7.4% to 9.9%. That's more than a third, right, in proportional terms. That's huge. And it's larger than many, interventions or exposures that have an effect on preterm birth. But comparable to some other infectious diseases during pregnancy, the negative effect is relatively similar across groups defined by race, ethnicity, and socioeconomic advantage. Okay, so ceteris paribus, given what we have found, the COVID pandemic should have a negative overall effect on preterm birth through this direct pathway, right? Through maternal infection. However, of course, there might be other, even potentially offsetting indirect pathways of influence that would shape outcomes at the population level beyond infection. That, of course, forces us to turn to the population level question, which is what I'm going to do now. So let's address that question. To do that, I'm going to implement a time series analysis of aggregate weekly data. So I'm going to summarize my data using weekly averages. I'm going to use ARIMA models to account for trends, seasonality, and other sources of temporal autocorrelation in the data. I'm going to use, at the time of so-called intervention, the week in which the shelter-in-place order was implemented, right? That's where quote-unquote treatment started. So this is the raw data, right? From I have data dating back to 2010, but here, so that it's more easy to follow. I'm going to show you data from 2016, and we see. So each hollow dot is a week, the proportion of preterm births for that week. And so we just summarize the data using this red line, nothing linear about it, like this non-parametric summary, right, a lowest formulation. And what we see is that there is a weak trend is showing an increase in preterm birth. There is marked seasonality, nothing new about this, with people who study preterm birth have documented this. The red line is March of 2020, right? And what we see here is unclear, as it usually is with raw data. Does this portion indicate a decline in preterm birth? Perhaps. Does this part indicate an increase in preterm birth post-intervention? Perhaps. We don't know. That's what we do modeling, right? So I'm gonna show you the extent to which there is statistically significant changes in the preterm birth rate that are suggested here using this ARIMA, this parametric formulation, right? When intuitively what I'm after is whether there is any statistically significant change compared to a counterfactual that would emerge from a pre-treatment trends, right? So if we were to predict from the past into this post-treatment area and then compare what we observe with what we have predicted based on the past, are there any changes? All right, so that's kind of the intuition behind the technique. And this is the first set of findings. In the bottom, I have time. I don't know if you can see this or is it tiny. It's a little tiny for me, but I hope you can see it. So here time is measuring, it's 4-week intervals. So there's not quite months, but it's almost months. They're quasi months, right? So 4-week intervals from March 2020 all the way to September 2021. And these are the ARIMA parameters capturing changes in the preterm birth rate compared to this counterfactual based on historical trends. And the answer is very clear. Consistent with some other research, there is a beneficial decline in preterm birth early in the pandemic and also in November of 2020, right? However, then the preterm birth rates change and there is a statistically significant increase in preterm birth during precisely the winter surge of COVID infections, right? December, January of 2020, 2021. And then there is kind of a return to baseline, right? Not significantly different from the trend predicted from the based on the past, right? So what is true? Did COVID increase, result in an increase or a decline in preterm birth? It depends on where to measure, which really highlights the relevance of this the ability to have continuous data over an extended period of time and possibly, without much in terms of a lag, right? This is the main kind of descriptive finding. If you're a demographer, the first thing you're thinking, right, is, well, to what extent do changes in fertility account for this, right? If different people were having births post-pandemic, based, for instance, on age, education, whatever other socioeconomic characteristics that are associated with preterm birth, it might be this compositional change what accounts for these trends rather than any effect of the pandemic. So my first extension from this is I'm going to account for all for these observed sociodemographic factors, right? I'm accounting for a mother's age, age squared, birth parity, education, race, ethnicity, and so on and so forth, the usual suspects, right? To account for the potential of compositional change in the births that we get to observe after the pandemic. And what we see, and this is, the circles are what I showed you before, the triangles is accounting for compositional change based on observed factors. And what we see is not much change at all. In particular, we thought that, look at this point. These births are those who were conceived at the very beginning of the pandemic. We thought if compositional change plays a role, this estimate might change after we account for compositional change, but we didn't find that. This doesn't seem to be any impact of the pandemic on low preterm birth. Doesn't appear to be driven by the compositional change of the observed births. The second question that you may be considering now, how about obstetric delivery practices, right? It might be the case that because of the pandemic, medically indicated preterm births were altered, right? So many people speculated about a change in the probability, in the proportion of birth inductions or cesarean sections. So we control for the delivery mode, right? Accounting for inductions, cesarean sections, and so on. And the third set of estimates, the squares, report trends after we account for that, and we see basically the same trends. So this is not a story about either compositional change or delivery mode. And you know, we want to understand what drives these trends. So, well, this is a summary in which I collapsed months into periods, but you saw the more detailed information. So let me take stock and move to the next question that this question invites. So the proportion of infants born preterm dropped early in the pandemic, but it then increased around January of 2021, which coincides with the peak of the winter surge in infections. And then it appears to have returned to baseline, right? Or baseline, I mean, whatever it was predicted based on the past in the spring of 2021. So this obviously invites the next question, which is, to what extent do COVID infections account for the increase in preterm birth during the winter surge? Is this a story about the direct effect of COVID infections, which, you know, it's very reasonable because we see an increase in preterm birth that fully coincides with the winter surge in infections, right? So in order to address that question, the way we're going to do that is we're going to rerun our ARIMA models, but excluding all births that had where the mother was tested positive for COVID, right? Because we have micro data on COVID infection among all pregnant persons, we're going to exclude these observations and run our ARIMA models again. And this is the results. So the blue circle is what you saw already, is the trends for everyone. I should say, well, these trends are only include singleton births. I exclude multiple births, okay? But for everyone except for that. And then I'm gonna, that's for all analysis. And then in purple, I'm gonna exclude births where the mom was tested positive for COVID. And of course, as we expected, the early pandemic declines in preterm birth are not accounted for COVID infections at all, because infections were very low during this period. But the substantial increase in preterm birth during the winter surge of infection is largely accounted for by this direct mechanism. Moms came to give birth with COVID infection, and COVID infection during pregnancy increased the chances of preterm birth. So when we remove COVID infections, we see that the increase in preterm birth is much reduced, right? I should pause here and kind of provide a little bit of benchmarking. So this increase in preterm birth here is of the magnitude is about half of a percentage point. This is at the population level not negligible at all. It's a lot more births that would have not been preterm had the pandemic not happened. I mean, to get just a rough sense, every month in California, we see about 35,000 births, right? So a half a percentage point, even in 1 month, means a lot of births, right? So, so this is a question about the role, the mechanisms, right? The direct role of COVID infection during pregnancy. And my final question is my initial question, perhaps, is a question about socioeconomic disparities, right? To what extent is there socioeconomic heterogeneity, stratification in these trends that I've shown you, right? In the trends in preterm birth during the pandemic. And to address that question, I'm going to stratify by the mothers educational attainment as my measure of socioeconomic disadvantage. These are the results. So the first thing to notice here is that I switched the axis of these graphs to accommodate these three groups, right, defined by mom's educational attainment. So I have mothers, persons giving birth with a high school diploma or less, with some college, and with a BA or more. These are the groups. And I kind of rotated the axis, right, clockwise. So my graphs before were horizontally organized by time, and now they're vertically organized by time, but I'm showing you the same thing. Still, the zero line means no change based on, the past. And what we found here was, to me, really strikingly sad, because I mean, of course, we can look at different parameter estimates and, do significant testing, which we should do. But to give you a bird's eye account of this finding, it is that the beneficial decline in preterm birth early on in the pandemic was more pronounced and more persistent among the most advantaged mothers. It's not that there wasn't any decline among the disadvantaged mothers. Look at this parameter estimate. But if you look at the entire period, the benefits, so to speak, of the pandemic on preterm birth, driven perhaps by the ability to rest, to stay home, whatever it is, were more pronounced and persistent among the most advantaged groups. In sharp contrast, the toll that the pandemic took in terms of an increase in preterm birth affected only the most disadvantaged group. Look at the parameter estimates for mothers with some college or BA or more. There's no increase in preterm birth at all. The increase is narrowly concentrated among mothers with very low levels of educational attainment, right? So with this, we did a bunch of robustness checks. I'm happy to discuss them, but otherwise I'm gonna just wrap up. So the reduction in preterm birth early in the pandemic is concentrated among mothers with a BA or higher education. In sharp contrast, the increase in preterm birth during the winter surge of COVID infections only affected mothers with a high school diploma or lower educational attainment. So we do find evidence consistent with a very highly stratified consequences of the pandemic on infant health. And this is very worrisome. We know that the pandemic is expected to exacerbate inequality in multiple ways. The findings that I've shared with you today suggest a very nefarious and enduring pathway, which is the legacy of prenatal exposure to an unequal pandemic environment. So with that, I thank you very much, and I conclude.
Thank you so much, Florencia. That was such a wonderful talk. We are actually at time, but I will maybe do one question, and I think we've answered Ron's first question, and Nathan's question in the chat, I think, has been answered. And then Ron had a few more questions. Ron, do you want to pick your favorite question to ask?
Well, it's about, I wasn't clear, is the idea that having had COVID at any time during pregnancy might raise the probability of preterm birth, or is the idea that having COVID at any moment will raise the probability of preterm birth at that moment? And I guess that's my basic question. And along a way of following up on that might be to do the ARIMA analysis with a sort of distributed lag or distributed structure in which you the statewide prevalence or subgroup prevalence up to 9 months previous to the birth, something like that, could have an effect, an estimated effect, to see if maybe exposure earlier, because in a surge, more of the women delivering will have just gotten COVID then, but when prevalence is lower, more of them will have longer ago exposure. That's what I'm thinking.
Yeah, that's a very important point. Can you hear me okay? I decided to turn my video on just not to talk to you like incognito. So this is a terrific point. So to your latter point, yes, indeed, doing using kind of a distributed lag or event study makes a lot of sense, and that's something that we're exploring now. But to the former part of your question, this is my reasoning, and you can disagree with me. So it is certainly true. We have convinced ourselves a battery of analysis that what is measured in the birth certificate is COVID infection measured at the time of labor and delivery. That is, I believe, completely correct. So if infection had occurred early in the pregnancy, we wouldn't observe it virtually at all. So in our models, that would be a confounder, right? And a confounder with a hypothesized very clear direction of the omitted variable bias, which is early pregnancy infection. Most likely, if it does have an effect on preterm birth, it's negative, right? The same as concurrent, infection late in the pregnancy. That's very likely. And at the same time, because based on what we know today, it's very unlikely to have two subsequent infections during pregnancy, right? So one earlier, one later. So there would be a negative correlation between this confounder early pregnancy infection and late pregnancy infection. Given that structure of associations, right, our omitted variable bias will result in an underestimation of the effect at the individual level. So we will capture, we will be underestimated. What we showed you is a lower bound in the effect of infection. That I think is correct, which, it's informative, but doesn't address the question to what extent early pregnancy infection matters. And I see your second point about including this lag in the infection to try to push this as much as possible, which is, I think, a wonderful suggestion on one of the things that we will be doing.
Thank you.
Wonderful. Thank you so much. I'm going to end our official session because we're just a little bit over time. Let's thank Florencia Torche for this wonderful,
thank you
wonderful
so
work.
much.
Thank you for sharing.